members. AREP is Academic Radiology Education Program. We are a small group of radiologists from Bhutan, from Cambodia, from Nepal, from Indonesia, from Laos, Myanmar, Mongolia, Thailand, Vietnam, and Iraq. And we broadcast our live webinar on the first and the third Sunday of the month. We are now in cardiothoracic session. This is a special session since we have a chance to work with the STR, or Society of Thoracic Radiology. STR is a non-profit organization, and in the official website has a ton of free educational material that may be useful to you. And there are a few announcements, a couple of announcements I would like to make. The first one, this month will be the last month for our quiz question. And at the end of after the Q&A session, I will show you a quiz question, so you can have your phone ready to scan the QR code, so you can click in, scan the QR code and choose the right answer that you think that is the right answer. And we will have the polling time today 3 minutes. Not 1 minute, we're gonna have 3 minutes because the questions is a little bit long. And the second announcement is, please help us to improve our webinar by scanning the QR code for evaluation. The people who complete the evaluation will get the certification of attendance, and we will send it to you into your email address. This is for registered members who join the webinar by using the Zoom link. And today we are learning from the cardiac guru today. Dr. War from Myanmar Radiology Society is our moderator today. I would like to pass on this task to Dr. War. Dr. War, please.
Thank you, Dr. Tapening, for the opening remark. I'm Dr. Wa from Myanmar. Good morning, good afternoon, and good evening, wherever you are attending from. We have a distinguished speakers today and lecture focusing on coronary CT 101 cases. The talk will be given by Dr. Samita Patel. Dr. Patel is a professor of radiology, cardiothoracic divisions, and director of cardiac CT at the University of Michigan. Her area of interest includes cardiac and vascular CT and HRCT. She currently serves as chair of the STR Inter-Society and Global Outreach Committee and is passionate about providing educational endeavor to residents and practicing radiologists in underserved countries worldwide. She also served on the RSNA Cardiac Scientific Committee and radiographic panels for thoracic and cardiac radiology for the RSNA and is a senior reviewer for the ABR Online Longitudinal Assessment Group for Cardiac Radiology. She has over 80 peer-reviewed publications and book chapters and has given more than 200 invited national and international lectures. Dr. Patel will answer all the relevant questions at the end of the talk. If you'd like to ask the questions, please type in via the Q&A functions. Now, I would like to hand over to the speakers. Everyone, please help me welcome our speakers, Dr. Patel.
Dr. Patel, I think you are muted. Dr. Patel.
Sorry about that. Can you see my screen now?
We do. Okay. Yes.
I'm sorry. I've been having technical issues today, and I couldn't basically log on to my laptop so that you could be able to see me. So I've had to go to a PC that is a standalone PC that doesn't have a camera. So I'm sorry about that. But thank you so much for the kind invitation. And I'm going to be basically talking about coronary anatomy and anomalies. How do we look at these structures? So I'm going to start with cardiac chambers. And what I want to show you is we'll just go through everything that all of you know: ascending and descending thoracic aorta, the pulmonary artery, the SVC. So as we look at the cardiac chambers, as we are scrolling down, this structure that we see here is the left atrial appendage. On any CTs, you should be looking at the left atrial appendage to see if there is any thrombus, particularly if the patient's got atrial fibrillation. This is a narrow neck that the left atrial appendage has with the left atrium. The left atrium is the posterior and superior most chamber of the heart, and it basically receives 4 pulmonary veins. Whenever I'm looking at the pulmonary veins for pulmonary vein studies, I usually start at the bottom. I scroll up. I look at each pulmonary vein in turn, like the inferior right, the inferior left, and as we are going up, the superior right, and then here, the superior left. So these have variations in the anatomy. I'm not going to go over it, but we're going to go here to the SVC, and as we are going down, anteriorly on the right, we see the right atrial appendage. The right atrial appendage has many little pectinate muscles, and basically it's got this structure here, which is called the crista terminalis. Sometimes this can be very, very prominent and can be mistaken for a tumor, and it isn't. If you basically look at it on NPR, there are muscles that are coming from there going towards the wall of the right atrium. So the right atrium basically joins this right atrial appendage, joins the right atrium, and there are 3 structures that drain into it: the SVC, and as we scroll down, we have the coronary sinus here, and then we have the IVC. This here is the tricuspid valve, and this here, the anterior most chamber of the heart, is the right ventricle. The right ventricle traditionally has a trabeculated, very thin wall. The left atrium here, what we can see is the left atrium and the left ventricle. The left ventricle has a compacted, smooth, thick wall. This is the mitral valve, and these are the papillary muscles. So we're going to keep these structures in mind as we look at the coronary arteries. So looking at the 3-chamber view here, we have the left ventricle, we have the left atrium, we have the left ventricular outflow tract, the aorta, the anterior leaflet of the mitral valve, the posterior leaflet of the mitral valve, papillary muscle, and chordae tendineae over here that are attached to the mitral valve here along the ventricular surface. And this is a short axis view that shows us the papillary muscles, the anterolateral and the posteromedial papillary muscles. So moving on to what we're going to talk about today is the coronary arteries. There are 2 main coronary arteries, the right coronary artery and the left main coronary artery. And the left basically divides or bifurcates into the LAD and the left circumflex in the majority of the cases, and in the third of cases, it trifurcates. We'll look at that. So these coronary arteries arise from their respective sinuses, the right from the anterior or the right sinus of Valsalva, and the left from the left sinus of Valsalva, as you can see on this diagram here. These coronary arteries arise from the upper thirds of their respective sinuses, as you can see here. Now, this vessel that I'm showing you, you can see that it's trifurcating. So this cannot be the right coronary artery. This is the left main coronary artery that basically is arising from the upper third of the left sinus of Valsalva. Here is your right sinus of Valsalva. The right coronary, which is this vessel, is not arising from the right sinus, but it is arising above the sinotubular junction from that proximal portion just of the ascending thoracic aorta. This is called a high takeoff of the coronary artery. This in itself is not of any hemodynamic significance. They may have trouble trying to poke the right sinus of Valsalva during cath, and may have difficulty if you have the vessel arising higher. So it's important to know where is this vessel arising from. So when we look at the coronary arteries, whenever I talk to my residents, I ask them, which coronary artery would you see first as you're scrolling down? And invariably, 99.99% of them would say the right. But let's look. As we are scrolling down and we're looking at this ascending thoracic aorta, the vessel that we see first that comes off is the left main. Now, why is that? It's because the aortic root is at an angle. The left sinus of Valsalva is higher than the right if basically the aortic root is normal in size and not rotated. So you usually see the left main first before you start seeing the right. The right coronary artery is arising from the right sinus. It's heading off anteriorly in the AV groove between the atrium and the right ventricle. It's surrounded by fat and it's going around there along the acute margin of the heart, posteriorly in the posterior AV groove, before it branches into the PDA, which goes in the posterior interventricular groove, and the PLB, posterolateral branch, which goes to the left, towards the left ventricle and supplies the diaphragmatic surface of the heart. Now, when we look at the coronary arterial branches, we have various branches. So the first one is this guy, a little one, conus branch. Now, sometimes this can act as a collateral. That's why I'm showing it to you. This conus branch supplies the right ventricular infundibulum. You have this other branch that is arising from the proximal right coronary artery. It's heading off in this direction. This vessel, as you look at it here, it is the SA nodal branch. It supplies the Bachmann bundle. It's important for conduction. If it's damaged, it can cause certain conduction abnormalities. And as we go back, we've seen the PDA, we've seen the PLB, and where they bifurcate in between, you would have the AV node. So let's look at this in detail. This is using the cardiac software to lay the right coronary artery out. It usually looks like a C, as you're seeing down here. We're seeing some acute marginal branch, right ventricular branches over here. And you can basically twirl this around. You can even do a short axis to look at it when you're looking for coronary artery disease. The right coronary, this is a volume rendered image of the CT, runs in the AV groove. And the way you recognize the right atrium is that it's trabeculated. Here, we have the right coronary giving rise to the acute marginal and the PDA. And this guy is the conus branch that is arising separately, not from the RCA. And we'll look at the variation in its origin. The RCA in the back, basically you're looking at the posterior AV groove here, it's bifurcating into the posterior descending, and here is the posterolateral branch, PLB. So the right coronary artery supplies the right atrium, right ventricle, posterior third of the interventricular septum through the PDA, the SA and AV nodes when it's in the majority of cases. So we're going to look at all these branches. You don't need to remember them here. We'll look at the images. So the conus branch, as I said, it basically supplies the pulmonary artery infundibulum. It arises from the right coronary artery in more than 65% of cases, in about 20 from the ostial RCA, and in about 10-12%, it arises separately from the coronary sinus away from the RCA. This is the SA nodal branch that we had seen, and the SA nodal branch basically arises from the right coronary in the majority of cases, the left circumflex in less than 20, and it may arise from both vessels in about 10% of cases. And why is this important? It's very important for us to mention the SA nodal branch when we are doing pulmonary vein studies prior to them planning for ablation of the pulmonary veins, because if you have a coronary that's arising from the right side, that's okay. But when it arises from the left circumflex, it traverses in between the aortic root and the left atrium along the roof of the left atrium. And if they're going to ablate the wall of the left atrium for atrial fibrillation, then they may fry this vessel and it may cause conduction abnormalities. They may have to put a pacemaker in. So if we see the anatomy well, we should mention where we see that vessel. Coming to the last branch that I wanted to talk about here, between the PDA and PLB at the back of the heart, at the crux of the heart, where it forms the U, you have the AV nodal branch. So here is a volume rendered image showing the PDA and PLB. There's variation in anatomy of all these vessels. Here you have a single PDA. Here you have two PDAs. PDAs are rising a little bit more proximally in the posterior AV groove. The PLB here is small and the PLB here is big. So the anatomy varies in different patients. Moving on to the left coronary artery, the left coronary artery can vary. The left main can vary in length. It can be long, it can be short, it can be absent, and you may have separate origins for the left circumflex, the left LAD, and the left circumflex. So the left main predominantly gives rise to the LAD and left circumflex, but in about 20 to 30%, it trifurcates. It has to be a true trifurcation for us to call the middle branch a ramus intermedius. So the LAD supplies the anterior and anterolateral wall of the left ventricle, and it supplies the anterior 2/3 of the interventricular septum through its septal perforators. So we're going to look at the diagonals and septal perforators. What does it look like? So on the axial view, we're going to look at the left main. Here is the LAD. The LAD, basically, as it's going in the anterior interventricular groove, it gives branches on this side, which are the septal perforators, and it gives branches on this side that are the diagonals. So as we are going down, we are seeing the septal perforators here, and we are seeing the diagonals coming off here. The LAD, when we talk about it, we should mention how big it is. In this case, it's wrapping around the apex of the heart, and it's giving rise to all those diagonals. How many diagonals and how big is the vessel? Here we have the left circumflex. And the left circumflex in this case is a big vessel. What's important to recognize is this vein. This is the anterior interventricular vein that becomes the great cardiac vein. So the circumflex always travels with this great cardiac vein. So watch that. So as you're looking at the left circumflex, it's giving branches, but what is traveling with this vein? So as we are going down, this is the left circumflex going with that great cardiac vein. And in this case, the circumflex is dominant. And here, it's basically giving rise to the PDA, the posterior descending. And let's look at the rest of the branches of the left circumflex. So here, we have an obtuse marginal. There are multiple obtuse marginals, moderate caliber, large caliber obtuse marginal. And in this case here, as we are going here, this is your left PLB, left posterolateral branch. So this is a left dominant system. We've looked at the anatomy of the LAD and the left circumflex. Left circumflex goes in the left AV groove, LAD in the anterior AV groove. Here, we'll look at the right coronary artery. In this case, what happens is the right coronary is giving rise to this acute marginal before it becomes smaller in caliber, and it basically terminates in the proximal part of that AV groove because it's not dominant. So here is looking at a curve reformat of the LAD, and here are MIP views that we're looking at curve. And what we're seeing is that the septal perforators go in this direction, supplying the septum. The diagonals come off in this direction. So we call this D1, D2, D3. At our institute, we use from the ostium to the first septal perforator as a proximal LAD because the septal perforator is more constant in its position. And then from there to the second diagonal would be your mid LAD and then the distal LAD. So here is a curve reformat. We may have the LAD here is big, curving around the apex of the heart in both cases. Here it's giving rise to a single diagonal. Here it's giving rise to multiple diagonals, 3 diagonal branches. The left circumflex supplies the lateral and the posterolateral wall of the left ventricle. And the circumflex gives rise to the obtuse marginals. And in about 8 to 10% when it's dominant, it also gives rise to the L PDA, so the left-sided PDA, the left-sided PLB. The left circumflex often terminates as a large obtuse marginal branch. So here we have the left main, the left circumflex terminating as an obtuse marginal branch. Here we have the left main trifurcating And this is your, these are your obtuse marginals. This is your left circumflex going with the vein. So OM1, OM2. And here you've got a trifurcation where this middle branch, basically, we're going to look at that in a minute. But here we have the left circumflex giving rise to a single obtuse marginal. Here you have the left circumflex giving rise to multiple obtuse marginals. And this middle branch, where it's a true trifurcation, is called a ramus intermedius. This ramus intermedius can be big in size. It basically can give you, it can basically supply a significant portion of the OM and diagonal territory. And oftentimes when that ramus intermedius is big, the diagonal arises a little bit more distally. Look at this. This diagonal D1 is much smaller in size than than the D2, because this guy is doing a job through its branches supplying that portion of the myocardium. And it's important for us to evaluate this vessel, particularly when it's big in size, because it may be diseased with atherosclerotic plaque. So, so it can be variable in caliber. And when we talk about the dominance, let's look at some volume rendered images. Here we have the right side that is dominant. We've got the PDA and PLB coming off the right side. And how can we tell on a volume rendered image? So, you know, we can usually tell on the usual, even our normal, when we scroll through our axial images, we can tell. But if we had a volume rendered image, how can we tell? We can see that the wall of the left atrium is very smooth. So that is the left side, and this is the right side. So here you have the PDA coming off the right. This is a right dominant system. Here you have a PDA coming off the left. This is a left dominant system. You may basically have a PDA coming from the right, a PLB coming from the left, that is a co-dominant system. You may have absent PDA and PLB, and you may have branches that are coursing towards the septum, and this would also be a co-dominant system. So basically, I've gone over the normal anatomy. I'm showing you that the left main here would be one you would look at. You would divide the LAD into thirds, and I've shown you how to do that. This is the ramus intermedius. The circumflex proximal circumflex is from the ostium to the first obtuse marginal. Then you have the distal circ. The RCA you divide into thirds, and then this would be along that acute margin of the heart, the mid RCA. This would be in the distal groove. This would be in the proximal AV groove. And then we have the PDA and PLB. And this is from the SCCT guidelines for interpretation and reporting. So moving on to the second half of the talk, which is coronary artery anomalies. These were considered to be very rare before because they were picked up either at cath or autopsy. But now that we have CT, we are seeing them more and more in, almost 6% of cases. These are often an isolated finding. We find them incidentally, but they may be associated with symptoms, or they may be associated with valvular heart disease or congenital heart disease, such as tetralogy of Fallot or transposition of the great vessels. So why are these important? A small number of them can be hemodynamically significant and cause ischemia, shunting, or even sudden cardiac death. And then the majority of them are not hemodynamically significant. So let's look at the hemodynamically significant anomalies first. So death often occurs when the coronary flow is compromised. It could be due to an anomalous vessel that courses between the aorta and pulmonary artery. It may be in the wall of the artery as it's doing that. It may be kinked or tortured, or may have torsion, or it may have a slit like coronary artery orifice. So when we look at the coronary arteries, we are looking to see, is the coronary artery arising from its respective sinus? If not, is it arising from the opposite sinus or the opposite artery? When it does that, is it taking an interarterial course, an interarterial intramural? These are too many word slides, but we're going to look at all these examples. Or is it terminating abnormally, like you would see congenital coronary artery fistula? So let's start. So whenever I'm teaching my residents, I always tell them, look at the left sinus of Valsalva first, because we see the left main arising from the left sinus first as we're scrolling down. So as we look at that left sinus of Valsalva here, It's an empty sinus. There's nothing arising from there. So I tell them to look on the right, and we look and see that the right coronary artery is arising from the right sinus of Valsalva. And then in this case, we also have an additional vessel, this guy, that is arising as a common trunk with the RCA. And this vessel, what vessel is this? This vessel is long. It's trifurcating into 3 branches. Let's look at that branch. That for sure is the LAD because it's going in the interventricular groove. This guy is the left circumflex because it's going along in the posterior, it's basically going in the left AV groove along with this vein. And that middle branch must be a ramus intermedius. So this is the left main that is taking an interarterial course between the aorta and the pulmonary artery at the level of the pulmonary valve. This is a hemodynamically significant anomaly. This is what we see in between these 2 structures. So in this first paper, 19% of sudden deaths in young athletes were from anomalous left coronary arising from the right sinus of Valsalva or opposite sinus. And in this paper, where over 6 million military recruits underwent intense physical training for 8 weeks, there were 227 deaths. A third of these were from the left coronary artery arising from the opposite sinus. And 2/3 were those of hypertrophic cardiomyopathy, because that's much more common. So let's look at this case. This was a young high school kid. He was a soccer player. He played soccer the night before. And the next day, here in high school, you have to do mile runs. And so he was doing his mile run the next morning. And on his final lap, he had substernal chest pain and he collapsed. He was taken to the nearest hospital. He wasn't at our hospital. And there they found that he had ischemia, anterolateral ischemia up to 10 millimeters. His enzymes, cardiac enzymes, his troponins were elevated. He had a cath. They did not see any coronary artery disease, but they saw that the left main was anomalous and they saw haziness in that region. They thought, could this be due to spasm or could it be due to ruptured plaque? He went into cardiogenic pulmonary edema. An aortic balloon pump was put in and he was sent to us. So these images are a little bit noisy. And also, I'm not sure where the pediatrics gave this patient a beta blocker. So what we're going to do is follow the same rule. Look at the left sinus of Valsalva, not at anything else. When we look at the left sinus, we don't see anything arising from there. When we look at the right sinus of Valsalva, we see the right coronary arising there. So here is our LAD. Here is our left circumflex. Let's follow those backwards. So when we follow, the myocardial territory is usually preserved. So we follow these vessels back and we are going back, we're going back. So it joins, forms the left main. And so this guy is the left main. It's arising from the right sinus of Valsalva. It has an acute angle takeoff as it's arising from there. It's difficult to see what's happening there, but when I did use the cardiac software, what I see is that this left main has an acute angle takeoff, but it's very, very narrow. Notice this is very narrow compared to more distally. And when I look at it orthogonally on cross-sectional views, this is what I see. So this is called a slit-like coronary artery orifice. CT spatial resolution is not the best, so we don't see a wall, but when we see something like this, this vessel is in the wall of the aorta, and it's being compressed there, and it is in between the pulmonary artery or the pulmonary outflow tract, and it's basically being compressed every time during exercise or systole and things like that. So acute angle takeoff, slit-like coronary artery orifice. And more distally, your coronary arteries look normal. They should look round. They shouldn't look like they're flattened side to side. So this was a paper from Paolo Angelini from the Texas Heart Institute. He's done a lot of work on coronary artery anomalies. This is an IVUS. IVUS is the gold standard to look at these. And he basically says that the proximal segment of the left coronary consistently, the intramural course is hypoplastic as determined by its circumference, and it has an ovalloid deformity, lateral compression, and it worsens with exercise. So this is very, very significant and can cause sudden death. In this patient, it caused a big myocardial infarct. You can see low subendocardial low attenuation along the septum, along the anterior wall, and you can see hypokinesia. This patient had sustained a humongous infarct to his LV. You can see that his LV is dilated, and here's your subendocardial low attenuation compatible with the infarct that this patient had. So what is the treatment? The treatment for this is different from that first one. You unroof the coronary artery. So what is unroofing? This vessel, if the surgeon puts a metallic probe in here, his metallic probe will go here and he will feel the wall outside, and then the probe will come out to the epicardial surface of the heart. He is going to cut and release the compression along this side, the inside of it. And here they may do fenestration, like make little holes so that the compression is released. So this is very different from what we would do for this vessel. So in this vessel where you have an interarterial course surrounded by fat between the two structures at the level of the pulmonary valve, you would do bypass surgery or reimplantation. In this case, you would do unroofing. So I see this in many cases, even when I'm reading normal, like aortic CT. So it's important to recognize this. The surgeons want to know what is the anatomy of the coronary artery. So coronary artery termination can be asymptomatic. So and it is basically coronary artery fistulas. Patients can develop a myriad of cardiac symptoms, including bacterial endocarditis, ischemia, infarction. They can develop fistulas, and the fistulas can rupture. So when you have, even though it's reported that fistulas are more common to the right heart, I don't see them so commonly to the right side. I most commonly see fistulas to the pulmonary artery, termination in the pulmonary artery, and then I have seen them terminating in the SVC and coronary sinus. So myocardial perfusion may be diminished due to Steele phenomenon. So here we have whenever you see fistulous and collateral flow, you see a lot of large vessels and tortuous vessels. So here you've got an LAD that's big. You've got a vessel that comes off as if it's a septal perforator, but it's not. It's a fistulous connection to the pulmonary artery with a large aneurysm down here, and aneurysms also forming from collateral flow in the bronchial arteries. And this is what you're seeing here from the LAD. We have a fistulous connection, and this is to the right pulmonary artery here. And there are many other ones. And here, where you've got collateral flow, this is your right coronary artery. And when we look at it, it's tortuous and it's big. And here it's terminating in the coronary sinus. So RCA to coronary sinus fistula. And here, when we look at this, we see the left main, the LAD is normal in size. When we look at the left circumflex, it's big. And if you're watching that left circumflex as we are going down, it's tortuous there, it's going here. But keep watching it, and we're going to go towards here and then watch what's happening there. So here, the vessel is joining to the SVC. So left circumflex to SVC fistula. So it's important to recognize these fistulous connections as well. Recently, I had a very complex one where there were multiple connections, not just a single connection. And the interventional cardiologist wanted to go over the anatomy to see if anything could be done percutaneously for that patient. So it's important for us to recognize that. Now, this anomaly, anomalous origin from the pulmonary artery, is rare. It's a serious congenital anomaly. Infants die in early childhood, 90% of them in the first year of life. And coronary Steele develops because blood flows from the pulmonary artery into, from the coronary artery into the pulmonary artery, and doesn't, leaves the myocardium basically starved. So here, when we're looking at that we're going to look at the ascending thoracic aorta and the left sinus of Valsalva. We don't see the left arising from there. We do see a right arising from the right side, and the right is big. So what about the left? Let's go to these guys again. Let's follow them backwards. LAD and left circumflex, and here they're joining to form the left main, and the left main is arising from the pulmonary artery. So this is called anomalous left main, anomalous left coronary artery from the pulmonary artery, a serious condition. This patient lived to adulthood, but these patients develop a lot of collaterals between the right and left side, and you see these vessels like this. So it's important to recognize this. Now, this was from our institute where this patient was 64 years old. He came in with pneumonia. His pneumonia was treated, his fever, got better, but he continued to be short of breath. They did an echo and they saw echolucent structures with diastolic flow near the tricuspid valve. And they were wondering if this patient had a fistula. So I'm just going to go and show you this here. So this looks like a bag of worms, collaterals, numerous collaterals that are here. So let's do our due diligence looking at the left sinus of Valsalva, the left main arising from there. Look at the right sinus of Valsalva, the right coronary artery is not arising from there. So we're going to look at the right coronary artery. We're going to follow it backwards here. And what we see basically is that the right coronary artery is arising from the pulmonary artery. So this patient was a boxer. He lived without decompensating for 64 years. And now he's got now this was diagnosed and he was treated medically for this condition. So people can live with an anomalous coronary that arises from the right. I've only seen a couple of cases such as these, I haven't seen any where they have repaired it because I don't do peds, but it's something to keep in mind if you're doing peds as well. So anomalous right arising from the pulmonary artery. So this one, I'm just going to show you that this came to us from an outside institute. And this patient had lightheadedness, dizziness, and chest pain. And they at cath, they basically said that the left main was arising from the right cusp and supplying a dominant normal RCA. So whatever they said here wasn't quite what we found. The patient had global hypokinesia. The pediatric people were asked to look at this, even though this was an adult patient. And when we look at these coronary arteries, we're going to look at the left sinus of Valsalva first. Nothing arising from the left. Look at the right sinus of Valsalva. The right is arising from the right. When we look at this LAD, and we look at a very small circ, let's follow that LAD backwards. So we see the LAD going between these two structures, the aortic root and the left atrium, and watch what it's doing. So there it is, and it's coming off the right coronary artery. So the right pulmonary artery, it's coming off the pulmonary artery. And this patient's 48 years old, now getting symptoms. The patient had multiple collaterals. So when we go here, we're seeing collateral flow. I'll show it to you on a MIP image because it's much better seen. So we're going to look at this aorta. So we're seeing these collateral vessels here. So these collaterals are bronchial artery collaterals that are going here and joining the pulmonary artery. Anteriorly, I'd mentioned to you about the conus branch. So what's happening is this conus branch is forming collaterals and it's joining the LAD. So what's important for us whenever we see something abnormal is go distally, follow that vessel proximally. If you see collateral vessels, see where they're joining, use other things. So here, what we have is the left main. Here is that bronchial artery collateral to the left main. And here is the conus to the LAD, which has basically formed collateral flow. And this patient was able to survive for this long with that. Lastly, we're just going to spend a few minutes to talk about anomalies that are not hemodynamically significant. These include all these transseptal, retroaortic, prepulmonic. What do they mean? So what we look at again, is the coronary artery arising from its sinus? If not, is it arising from the opposite sinus, opposite artery, or from the non-coronary sinus? Is it going between the aorta and it's usually subpulmonic in this case, not at the level of the valve. And oftentimes it's subpulmonic or it may dive down into the septum, and this is not hemodynamically significant. Or is it going behind the aortic root or anterior to the pulmonary artery? So let's look at some examples. We're going to look at the transseptal first. In this case, we're going to look at the left sinus of Valsalva, nothing coming off there. Right sinus, we do have the right coming off there. And then if we go and follow this LAD backwards, LAD and circumflex backwards, what we see is that here is the vessel. Here it is. So it's coming off the right sinus of Valsalva. It's going subpulmonic. It's basically giving rise to a septal perforator in the septum. But the way to look at this well is to basically look at a sagittal view. So when you look at a sagittal view, what you see is that you have your right coronary artery here. Now, when you look at this vessel, this is your left main. Watch it. So this left main is basically going subpulmonic below the level of the pulmonary valve. Here is your interventricular septum. It's diving into the proximal third of the interventricular septum because your septum is coming up to here. It's giving rise to a septal perforator before it comes up to the epicardial surface of the heart. So this is transseptal, and that portion that is transseptal is protected inside. This is protected inside the wall of the septum. Separate origins of the left main and right coronary artery, and you can see that it is taking a transseptal course over here. So this one is a similar one where I'm just going to show you there's a little guy that's coming off here, and that is a septal perforator because it just finishes off there. We have the LAD. When we look at the LAD, we look at this guy. We're going to go backwards, and it's going in the septum here, and it's coming basically off the right side here. And I'll show that to you, but in this case, the left circumflex is this guy, which gives rise to a diagonal, but this is the circumflex because we can see that it is the circumflex here. It is going between the aortic root and the left atrium. This is called basically a retroaortic course. Retroaortic course, and this one is a transseptal course. So basically just showing you here, retroaortic course, but we're going to look at this septal perforator because you can see the septum really well here. This was in the wall. Sometimes it can be in the wall of the RVOT, but it's gone inside the septum. It's given rise to a septal perforator before it comes up to the epicardial surface of the heart up there. So it's different from this one that I had shown you where it is between the aorta and the pulmonary artery at the level of the pulmonary valve. This is interarterial. So retroaortic, and the last one is prepulmonic going anterior to the pulmonary artery. So here we have the left sinus not giving rise to anything, right sinus giving the right coronary artery. And then when we look at this vessel here, it's coming off the right sinus of Valsalva separately, and it is supplying both the LAD and the left circumflex. So this is the left main that has retroaortic course. The left circumflex taking a retroaortic course is the most common anomaly that we would come across, but this was the left main. And this case here is one that basically we're going to look at the left sinus of Valsalva, nothing coming off there. Right coronary artery coming off the right sinus of Valsalva. Let's look at the LAD and follow it backwards. And as we follow it backwards, the LAD is going anterior to the pulmonary artery or the pulmonary outflow tract, and it's coming off separately from the right sinus of Valsalva. And so that is a pre-pulmonic course. And the circumflex, if we follow the circumflex, which is here, and we follow it backwards, the circumflex is going retroaortic, and the circumflex is coming off the right sinus of Valsalva. So three separate origins, and here is your pre-pulmonic LAD. Volume rendered images are excellent to look at the coronary anomalies as well as bypass grafts. So otherwise, I don't find them very useful, but I really, really find them useful to show this. Sometimes you may have a single vessel that gives rise to all coronary arteries. Here, the left main is giving rise to the RCA and the LAD as well as the circumflex. And if it has disease more proximally, the entire myocardium is jeopardized. I've shown you the separate origins for the LAD and left circumflex. This was that last case that I showed you with the LAD taking one of the cases that I showed you before, transseptal course, the left circumflex. So three separate origins for these three different vessels from the sinus of Valsalva, left sinus of Valsalva. And lastly, I'm just going to show you, because we are short of time and I want to give time for questions, I'm going to just show you what myocardial bridging is. So myocardial bridging, we see it more commonly on CT than they see it at cath. Basically, the coronary artery is usually surrounded by fat. But when the coronary artery, basically dives down into the muscle, it's called myocardial bridging. That part of the vessel is protected, and you get usually disease more proximally in the vessel. So myocardial bridging is when when basically the vessel may go superficially into the myocardium, or it may go deep into the myocardium, like this here. And in itself, it's of no hemodynamic significance, but sometimes it can cause some problems with ischemia or ventricular fibrillation, but it is rare. So by far, this is considered benign. So this is myocardial bridging. What I'm going to basically show you is one case here where you're looking at, when I ask my residents, where would you see disease in patients with myocardial bridging? So the vessel in the septum is protected, but you see basically atherosclerotic disease proximal to the vessels. So when you look at it here, you're going to see the left main here, and then you're going to see the LAD here, and the LAD has mixed plaque, non-calcified, calcified, and before this vessel dives down into the muscle here. So myocardial bridging. So I'm going to end by saying that do look distally at the vessels if they don't arise from their respective sinuses. Always look at the left sinus first. Recognize the interarterial going between these two structures at the level of the pulmonary valve. Don't forget to mention interarterial, intramural, because intramural is important. It has a different surgery, and we see these on our aortic CTs. Remember Al Kappa, you'll see it more in the pediatric population, but these are the surgeries. Look for different terminations of the coronary artery, because these fistulous connections, they would need either cath closure or surgical closure at times if they are big. These are the ones that are not hemodynamically significant: the transeptal, the retroaortic, and the prepulmonic. And I thank you for your attention. Any questions?
Yes, thank you so much, Dr. Patel, for the wonderful talks. It was very comprehensive and interesting information. Now we have a Q&A sessions, and we have some questions. The first question is, when we calculate coronary calcium score, do we need to count calcium from CABG graft vessel?
No. You should never, ever do a calcium score on patients who have had stents or have had bypass grafts. Never do them. Refuse to do them. That is not an indication. You only do it when the vessels, you only calculate it in the native vessels, and you should never, ever perform a calcium score. It is not indicated. It's not standard of care.
Yes, thank you. The next question is, in image acquisition, when we educate control of heart rate cannot be achieved, what ECG gating do we need to choose?
So what we do, it depends on the scanner you have. So we have a couple of vendors that we have, and one of them scans in one heartbeat. But if I have something like that, I sometimes ask them to open the window. They could do retrospective from 30 to 80, or I ask them to do systolic phase and diastolic phase. So 3 phases in systole, 3 in diastole. So, somewhere between 35 or 30 and 45 or 30, somewhere there. And then you would do somewhere from 65 to 80, because that way you would reduce the radiation dose. But if the heart rate is very variable, there are lots of there are PVCs or some other irregularities, you can do retrospective gating. But I would try to see if there's any way the cardiologist, we would consider bringing that heart rate. If it's very, very high and very irregular, I say I cannot do it, because if I do it, then I'm going to radiate the patient and I'm not going to be able to give you a diagnosis. Now, sometimes they just want to know what's going on proximally, like in the left main or in the proximal vessels. And sometimes we can tell, like if you've got retrospective gating, we may be able to piece together, in different phases and look at it if it's really, really important for them. But the distal vessels and the small vessels will be difficult to see.
Yes, it's so clear. And the next question is, When there is filling defect in the left atrial appendages, how can we differentiate? Is it a real thrombus or is it due to the slow flow?
We cannot. So we have to do left atrial appendage scan. So, sometimes you can see some enhancement. So thrombus usually is of very low attenuation. So you can sometimes see, that it measures, like in the left atrium, it may measure 360 Hounsfield units, but in the left atrial appendage at the tip, it's low, but it may basically have 100 or something. And then you may see that it doesn't have a clear-cut margin between the low attenuation and that. Then you can say that this probably is from slow flow, but the way we do it, we do a lot of left atrial appendage scans, and because we have EP and things like that. And what we do is a delayed scan. So we do a normal one, and then we do a delayed scan. And if you do a delay, it fills up in 99.9999%. Now, sometimes if that left atrial appendage is too big and it doesn't fill up, you can do prone imaging. If there's ever a question, always do 2 phases, and you do the delayed one for sure, because it will fill your left atrial appendage.
Yes, thank you so much. It's so clear. Are there any questions from Dr. Tapani? No. And there's one more question in the chat box. It said that please elaborate on malignant RCA caused from left ostium.
Oh,
Yes.
okay. So I didn't show a case of a malignant RCA. They don't like using the word malignant anyway, but like a hemodynamically significant, but I know what you're saying. So the RCA can arise from the left main or the left sinus. I have seen it arising from the left main, taking an interarterial course between the aorta and the pulmonary artery. Now, we see these more like when you see something like this, the patient, oftentimes, if the patient's older or middle-aged, it hasn't caused anything. So the current thought is that if the patient has that, to do a functional test, exercise them, do nuclear medicine, do whatever it is that you do to see, is this a hemodynamically significant lesion? And if it is, you would do an op. Otherwise, you would leave it, because there are many more of those cases than there would be of the left arising from the right sinus. So we do see this a few times. And I think the way to go, it also depends on the practice. The good practice is to stress them to see, is this a hemodynamically significant lesion, before they would attempt any sort of surgery for the patient.
Yes, excellent. And there's one more questions. What is the optimal contrast enhancement in coronary artery for diagnosis purpose? How high is Hounsfield units?
So I don't even measure. I like my hands. I measure it by my eye, but so I want to make sure that the coronary arteries are well opacified. I haven't measured the Hounsfield units, but usually our coronaries have Hounsfield units of at least over 300 Hounsfield units. But in Asia, where you are, you have very slim patients and small people, like you are slim. So and where I am, it's Michigan, and we have big people. And so the images can be noisy, and sometimes the contrast may not be good. But it's important to basically follow. We do smart prep, not timing bolus or anything. So we just make sure that the coronary arteries are reasonably opacified. If the patient is big, or if you have any problems, even at your end, you give a larger bolus of contrast at a higher flow rate. So it's important to give it at a high flow rate. You will basically opacify your coronaries really well. It's very, very important to opacify them well, because otherwise you're going to not see subtle plaque and some other things. And it also depends on the scanner, because sometimes I have 2 different scanners. I like one. I like even the workstation, the gray-white interface between what you're using. I like what I use compared to some others where you may miss seeing some plaque. So it's important to window when you're looking at this to see whether you have any plaque.
Yes, fantastic. And the last question is, how can we describe the percent stenosis of the coronary artery when we see the blooming artifact from the calcifying plaque?
So what's important is that usually SCCT, Society of Cardiac Computed Tomography, has a very nice paper on guidelines and interpretation. You should look at that. So the way we have our template, the coronary template laid out, is it's minimal stenosis up like 0 to 24, like, and 25 to 49 is mild. And so anything below 50 is not hemodynamic, not significant. Then from 50 to 69 is moderate, and above 70 is high. So when I have calcium, I window it such that I can take as much of the blooming out as possible. Then I look at the round thing as you're looking at the short axis. Is that calcium more in the wall, like outside, projecting more outside than inside the vessel? Oftentimes it's outside. And then if you window it and if you can see more than half the vessel, that's not going to be hemodynamically similar. But if it is going inside the vessel and it's obscuring the luminal view and you see a little bit of it, you can say that you think it is moderate, but this may be an overestimate due to a blooming artifact. But oftentimes it's in the wall and it's not that significant, even though it's so dense.
Yes. Thank you so much. And there's one more questions. Can you tell us how you inject the contrast for the coronary imaging?
We usually inject it, we usually have, we give contrast followed by a 50 mil saline push. So we have a BMI chart, like, because like I said, that the people vary in size. So we use a BMI chart that I'm happy to share with, but it won't work at your end because you've got smaller patients, but we use that to give the amount of contrast. Oftentimes it's roundabout anywhere from 60 to 7 to 80, but usually it's in that ballpark, and we give it at 4 to 6 mLs per second, and then we follow it by a saline push.
Yes, fantastic. There's no more question in the chat box. Therefore, I want to say thank you so much to the speakers. We are so grateful for your time and effort in speaking at our webinar. Your contribution was invaluable, and thank you for taking the time to be with us. And thanks everyone for your participations. Now, I would like to hand over to Dr. Tapening for the quiz questions.
I just want to apologize that you cannot see me on this and for the technical issues, and thank you for attending. Bye-bye.
Thank you, thank you. So it is now my turn to show you to share with you the quiz question. So I'm sharing the screen. Okay, let me do it again. Bear with me just for 30 seconds. Let me do this. Do you hear me?
Yes, we do.
Okay, good. Okay, I'm going to share my screen because no one speak to me, so I don't know that I'm talking to myself, just myself or not. Okay, here is my quiz question. Do you see my quiz? Yes, no?
Yes, but yeah, it's good.
Okay,
That's perfect.
so I have patients here, patient A, B, C, and D. They are from different scanner. And my question is, which findings is or are the most clinically relevant? Okay, I'm gonna click on the movie, and you can see it's gonna start running. They look a little bit different because they're from different scanners and different technique. And the QR code is on your right lower corner. Have your phone ready to scan it, and then pick one right answer that you think that is the right answer. Which one is most important? And we have to pay attention to. Dr. Patel have emphasized this at the beginning of the talk. So the polling time will be 3 minutes. I'm going to start collecting now. All right, we start now. Don't have seizure. It's almost like it's jumpy. So just look at it one by one. Just patient A first, pay attention to it, and then move to B, move to C, and move to D. Easy one. Okay, this month our price will be the headset, not the headset, the airport. "90 minutes left." Sorry, 90 seconds. I'm giving you a little time, more time, because some countries have slow signal, so we need to give some more time for those folks. 60 seconds left. "30 seconds left." All right. Time is up. Okay, we're gonna go over this. Look at the first case. So this is left coronary clasp. I'm sorry that I cannot stop it. And then you see the single origin here. That is the RCAs coming off right here from the left single origin from the left cusp, and is causing between aorta and kind of, this is my pulmonic valve, like at the pulmonic valve region. But the difference is, this is one, and the second one is, this is a pre-pulmonic course because it have a single origin from the right cusp, and it skips off the left main, the LAD and the circumflex here, anterior to the pulmonary artery. So that is a pre-pulmonic, which is a non-interarterial course. And then this one, the patient see the single origin from the right cusp, but it gives off the big left main coming across between our aorta and the anterior wall of the left atrium, and gives off the left system here. So the last one is almost, patient D is almost like patient A, but the difference is we'll show you. You look at this, see that how it takes off here, very tight. The origin is pretty tight here for the right coronary artery. For patients A, they still have some little space between aorta and the origin of the RCA here. But this one, look at it again. The origin of the RCA is pretty tight at the beginning. Okay, I'll have to wait and then watch it again. Here, look, see that? So that is really tight origin. So these two has anomalous coronary artery. So the answer is either D or A. Okay, and then Dr. Patel talked about this. We have interarterial course. Try to avoid the word in malignant course. They don't like it. And non-interarterial course. You don't have to remember this at all because there's no clinical significance here. But for the interarterial course, it has, because it's you used to call it malignant course. It's between aorta and pulmonary artery, and it's has higher risk of sudden death. The thing is, in patient D, is the patient has the slit-like origin, acute angle of the aorta, which is we call it intramural segment, which different from the patient's A. So this is how you will see single origin between aorta and PA, aorta and PA, aorta and PA. Those are interarterial cause. Look at this again. And let me see that. So this is the interarterial course, but there's no intramural segment. But this one has interarterial course with intramural segment. And look at sorry, this is from different patient. I just want to show you how narrow the orifice here is, here and here, right there. So this is almost like slit-like origin. So for the patient D, we did the treatment of choice will be unroofing coronary sinus. Like you go in and cut that part out and then graft it, make the origin bigger. And for the patient A, you do this. So the treatment approach is different. For the patient D, we do unroofing, roofing up coronary sinus. For the patient A, we do reimplantation. So the correct answers are A or D. All right. So, and I'm going to hand this back to the IT, because at the end of the webinar, please I stop sharing. So now the IT team, please put up the evaluation. If you would like to have the certification of attendance, please have your camera ready, and then scan this QR code, and then give us feedback. So we will make it, every time we try to make it better, and we need your suggestion. And I think that will be the end of it. And we have the rerun lecture in our YouTube channel. If any one of you have not subscribed to it, please do, because that lecture, you can go in and watch it anytime. So it is free for everyone. There's no cost to join the YouTube channel. And we will see you again next month. Next month will be a imaging approach to focal liver lesion. Okay, the speaker may be, I think this is not our speaker, but anyway, we'll send out a flyer to you. It's Dr. Teresa from Cleveland Clinic. Okay, we're gonna correct that. And thank you everyone for joining us today. And thank you, Dr. War and Dr. JP and IT team from Thailand. Thank you so much.
Thank you so much, Nat. Thanks, everyone.
Thank you.
Thank you. Thank you.